Okay, I'm gonna do a couple, it's kind of a two-part talk today, and I'll try to keep it into the time I have. It's a little bit of about me and my journey that Linda outlined and that fits into what I want to talk about today. It's no problem. Keep going, he said. The first part is really going to be this case that we've tried to piece together, which says, when you think about health, there's a kind of biomedical model that is successful in health, but maybe limited. And that ever since I've known Linda, since she got to know me, I've thought we're missing something, that if you're going to talk about health, you need to have a much broader conception of what health is really all about. And it must accompany things like exercise and social work and things like that, not as an ancillary, but as kind of a central piece of it. And I'm going to try to make the case and show you this study that we worked on together through NCHAP, that it's a better way to think about health, not just because it makes sense, but because scientifically it's more explains more than a biomedical model does for how people are going to do. The second half is going to be, then I went to California and talk about what it's been like to be a sort of social scientist, almost the anthropologist from Mars that Oliver Sacks describes in the Cancer Center, and trying to be a social scientist who talks to cancer doctors who are 100% sold on the biomedical model. So they set a high bar for convincing them that anything else matters. And show you how we've tried to put that into place now that I have a role as a department chair. So let's see if I can make this work. Sorry, guys. Can I advance these slides, or do you have to? Oh, on the screen. Sorry, guys. So, thank you very much. All right, got it. Thanks. I came to the University of Chicago in 2003 and was very fortunate right away to get a grant that let me do research for the next 5 years. So this Beeson Award from the National Institutes on Aging, I wanted to understand how emotions fit into decisions that people are making who are older. Sometime in 2006, this is, you get a very personal talk from me. This is my son, my oldest son. I started a clinic called the Specialized Oncology Care and Research in the Elderly Clinic at the University of Chicago. My son came, he was appalled because there was all these signs for the prostate cancer clinic and the breast cancer clinic. And he's like, where's your sign? And I'm like, look, they give me a clinic on Fridays. I'm lucky to have that. I don't get a sign. So he made a sign for me. There it is, on a 2x4 in his shop class. And he put it up over the lights. And it stayed there for the entire time I was at University of Chicago. Every clinic, because they couldn't get it down until I left and took it with me. Eventually, right before I left, they gave me an award for the clinic for the work it was doing to bring sort of this social science mentality to cancer care. I did become the division chief, and I just want to thank Linda, who's been there along the way. There's nothing like mentors. It's part of my story about what health is all about. Whenever I've had basically a time of crisis in my career, Linda was always there giving me good advice and in many cases giving me material support, and Martha McClintock as well as the whole NCHAP team. So I'm at the University of Chicago, so I don't get to give these kinds of talks that much. So you get to enjoy my, let's look back at the great books and let's think about the University of Chicago the way I remember and came here with. So Hippocrates, when you ask him, what's health? He said it was the balance of a bunch of things. And whatever we think of these things, blood, bile of two kinds, phlegm, and they all needed to be mixed together in some balance, some sort of overarching sense of health. Galen said it was the moderation of 6 factors, and he includes in there the environment, food and drink, sleep, wake, motion and rest, he calls it. I love the Hutchins joke about lying down till his feeling of exercise goes away. Retention and evacuation and passions of the mind was Galen's approach. Again, a pretty broad range of what health is really all about and pretty comprehensive. Osler came along, one of the modern founders of medicine, and he says the good physician treats the disease, but the great physician treats the patient with the disease. So I think we've, in some ways, having some signals of maybe we've lost a little bit of that. Okay, I'm going to jump in because to get through everything, I want to sort of get to the heart of the matter, which is a good University of Chicago inquiry style. So if you look in the Oxford English Dictionary at what is health, this is what you get. It's the state of being free from illness or injury, period. Pretty succinct. It's really essentialized, you might say, but it does feel a little stark and a little like maybe something's missing. When you go instead to the World Health Organization, they state health as a state of complete physical, mental, and social well-being, not merely the absence of disease or infirmity. Almost a complete opposite approach to what health is all about. And you would think after the history of medicine that this second one would be widely adopted and quickly incorporated into the way we do things. The actual matter is the opposite is basically true. I want to talk a little bit briefly about the history of this. Since the World Health Organization came along, there's been probably one serious attempt to scientifically bring this approach to the way we think about health fundamentally. And this was George Engel came forth with the biopsychosocial model 20, 30 years after that definition was put forth by the World Health Organization, in which he says we need a new medical model. And he wants to challenge biomedicine. And here's Engel's critique of the biomedical model of health. So if you look on the right side of this screen, Flexner, back in the 1920s, came along and looked at all the medical schools that were out there, how we were teaching people to think about health. And he said, you know what? This is really all just bad. We have no unified approach. There's all kinds of different ways people are talking about health. We need to get rid of a bunch of these medical schools. And we need to really concentrate on what matters most. And it was the rise of allopathic medicine. And I will encourage people, if you want to read about this rise of allopathic medicine, Paul Starr's book on the social transformation of American medicine. And allopathic medicine essentially said, the way to treat people for their diseases is to give them medicines, pretty much. That model has transformed the medical system in our country to what we have today, I would argue, and eliminated a whole bunch of other things. There's, as a side note, a controversy finally of people going back and talking about Flexner, and you look at the kind of institutions that were eliminated at the time that Flexner had his report, and they were very specifically those groups that we now recognize in what we would probably call structural problems, structural racism, really, because those schools were all eliminated at the time. And we went to the allopathic medicine model that we're still kind of recovering from. Paul Starr's book is great and ends in the 1980s, just about the time I got interested in these issues. And then the modern version of it is the ICD-10 codebook, if you haven't seen this. So anyone want to guess how long the ICD-10 codebook is? I'm looking at Albert, he might have a good guess. I wondered, I checked. It's 1,250 pages, the entirety of which is naming diseases in minute detail so that we can bill you for your left toe hangnail acquired by the crazy peacock you ran into. That is the degree to which we've gone down this biopsychosocial model. So Engel says this, he says, look, the dominant model really is a biomedical model, and molecular biology and probably genetics is really at its source. He says this model not only requires that disease be dealt with as an entity independent of social behavior, it also demands that behavioral aberrations be explained on the basis of disordered somatic, biochemical, or neurophysiological processes. And he said, we really need something different than this. I would argue he's exactly right. That is exactly the model, and we've more or less kept it. So here's the characteristics of these two models, thinking of it scientifically. So let's think of the biomedical model. It's reductionistic. What's the smallest entity, molecule, genetic piece of genetic code that explains things? It's very precise. It's measurable easily. Usually there's a lab test involved. It's a causal model. They even talk about mechanistic model of what health is about. and it has been wildly successful. All of our financials in many ways are built around this. The biopsychosocial model, on the other hand, is holistic. It's kind of diffuse, talks about a multidimensional way of thinking about health. It's kind of hard to measure. Yesterday was impressive. I saw the grad students doing an amazing job trying to measure these things and figuring out how do we get the right, precise way to assess these things. It's often a correlative science in which we have correlations that we rely on, but harder to prove causation. And it has been very slow to be taken up into the medical system. So we decided, and this was probably the funnest project of my life and is still ongoing, thankfully, to say, let's set aside whether each one of these models is better, about the theories behind them. Let's just make an empirical study of which one does a better job of explaining things on a head-to-head basis. So that was the premise we had when we started to write this article. And we had a great team of multi-specialty people studying this. And we had a data set that had measured important disease processes and had measured social science in the best way and said, can we compare these two? And at the time, my kids were younger, as Linda pointed out, they're off to college and high school. But I always liken this as the Horton hears a who problem. And the sour kangaroo there in the middle is the biomedical model. So you can use that and you can see how I tend to think about things, as Linda knows, where the who down there on the far right is saying, we're here, we're here, we're here. That's our biopsychosocial model. And the sour kangaroo is saying, I don't see it. I don't hear it. I can't tell where it is. I don't know what you're talking about. Okay, so we took the Oxford definition in the sour kangaroo, and we said, let's just count up the way we count up things in an ICD-9 code and say, you have an endocrine disease like diabetes, you have cardiovascular disease, we can measure your immune function. We're going to give you the biopsychosocial, we're going to give you the biomedical model as best we know how to measure it and say, how does it do in predicting things in a data set that's been across the country and that we haven't selected for? Then we took the WHO definition and said, what about health behaviors, mental health, sensory function, cognition, frailty, mobility? And if you add those things, do you get any additional information and does it help you? Okay, you just heard about NCHAP. It's a wonderful data set. I'm so impressed. We're so lucky to have Linda leading us on this. Older adults between the ages of 57 and 85. I won't say, but I'm almost there. Nationally representative of the United States. And we look at data between 2005 and 2010, the first two waves. And we have this computer-assisted personal interviews. So this is our data set. So doing this exercise is a little bit like, and you can tell I'm a fan of elephants, the old elephant analogy where there's these emissaries to the king. And he says, I've heard wonderful things about this magical entity called the elephant. We don't know what it is. We don't know anything about it. This was pre-internet days. So he had his smartest men who all happened to be blind. And he sends off and says, go find this elephant and tell me about it. And they went off and they came back and everyone had a different story to tell about the elephant. One said, it's exactly like a snake. Has this long body parts, it stretches out, moves around, it's just like a snake. And another one said, oh my God, it's not like a snake at all. It's a giant broad expanse, just like a wall. It's not at all like a snake, it hardly moves. And another one said, no, it's much more like the leaves on a tree. It flaps, it moves in the breeze. And of course, one had touched the trunk, one had touched the ears, one had run into the side of the elephant. None of them actually had the right picture of the elephant because they only had a small picture. And what they really needed to figure out what the elephant was about was for everybody to come together. So we took 54 variables from NCHAP in 15 different domains of health and defined them as abnormal by the standards of the day. So an example would be blood pressure. We just looked at the standard guides from cardiology and said abnormal blood pressure is blood pressure that's this high or this low, and here's what the normal is. And we did that meticulously. I spent quite a few hours with Martha McClintock, who's an amazing data collector, but meticulous as hell. And we categorized all 54 variables and then put them into special models called latent class models that classifies people based on these 54 variables into different groups. We applied it to the data set that was the medical model and one that was the biopsychosocial model, and we created these heat maps. So I'm summarizing a lot in this one table, and I'm going to orient you a little bit. And we've used the visuals so that you can kind of take a snapshot at this. We stole this from the genetics people to just show them we could do it too, which red is bad, green is good, and yellow is right in the middle. So you can kind of see in this heat map style where the least healthy people are in the red categories in those groups. Green is where they're most healthy, and yellow is somewhere in the middle. And the latent class model puts them into classes. So at the very top on the right, you can see green, yellow, and sort of red categories. And then down the side, we have all the different diseases that we could measure, including endocrine, cardiovascular, and at the bottom, cancer. So you can see this, and then you can see at the very bottom how it correlates with 5 years later. Are you alive? How healthy are you in other ways? And put them into groups that goes across. So there's these five groups that we found, and I'm going to point out some features of this. This is a pretty good snapshot of what a biomedical model of health might look like when you look at a data set. And what you find is almost everybody, 2/3 of the sample is healthy. You don't go to the doctor till you're sick in this model. And by this model, you're doing okay because you're better than everybody else with some exceptions. The other thing that's true about you, you don't have diabetes, roughly. Sorry, Albert, there's not so many who have diabetes. So diabetes tells you almost everything that you're going to learn. There's some breakdowns after that into whether you have cardiovascular disease or not. And you get a range of mortality outcomes that range between 14 and 35% in the next 5 years. So that's kind of it. And it's kind of unsatisfying, to be honest, because what it leaves you with is you probably should prevent yourself from getting diabetes. Not a bad thing, not deeply explanatory from a population side. Okay. Here's what happens when we add in the new variables that are from the social science side and psychological science, and we say, run the same models. You get penalized for adding variables in the model. So just adding variables doesn't make it more explanatory necessarily, because you get a certain penalty for that. So now what happens is you get two completely new groups that were unidentified the first time around. And the things that make a difference, that put you in these different categories, are how functional are you? Can you do the things you need to do every day? What's your mental health? Are you having depressive or anxiety feelings? How's your sensory function? Can you see, hear, taste, touch in a good way or not? And what kind of new explanatory things do you learn about? If you broke a bone and healed, it's a very explanatory feature of your history that we almost never pay attention to in the doctor's office. If you broke a bone and healed, you're fine. We don't even look. Poor mental health takes you from being in a very healthy group, and by this we mean depressive symptoms and anxiety symptoms. It's just barely puts you in a average category. It's our fourth category over. And the mortality explanation that you get, instead of that 14 to 35, you get 6% to 44%. I actually have a much better idea whether you're healthy 5 years in advance if I know these other things about you than all of those disease features that I talked about. So in almost every way you could think about it, this seems to be a better way to think about health for people. Okay, now hopefully I've convinced you at least a little bit that this matters and that we should be thinking differently, even though we're not. I'm going to try to convince you with this figure that on the far left side, is the biomedical model, and on the right is our NCHAP biopsychosocial model. Here's where the real rubber meets the road, and for the rest of the talk, I'll try to convince you about how we can change it. I'm going to click through this, and you're going to see a phenomenon, which is these are the same people on both sides. On the left side, they're in one model, and on the right side, they're in another model. Okay? If you're considered healthy on the left, you're in that blue category at the top. And if you're considered unhealthy, you're in that purplish category towards the bottom. Right now, our medical system, I would argue, thinks of you in that way. But if we're right about health, you're actually in the other categories that I'm going to show you. So there's some of you out there who we think is healthy who aren't so healthy, and vice versa. And if that's the case and we build a medical system around the first model, we're completely mistreating you in the second model. Okay, let me show you what happens. What you'll see is people come from all of the categories on the left and move into different categories on the right. We're misclassifying a lot of people in the current way we think about health. And you might say, well, that's cute. It's kind of a cute graphic. I like it a lot, of course. But does that really matter? Like, does that really make a difference? It just means that we're looking at people in a different way. Well, shortly after this came out, and that was in the Proceedings of the National Academy of Sciences, and it got a lot of attention. Another journal, JAMA, said, that's so interesting. We're going to write an editorial, not on our own article, but in one from another journal, which is pretty unusual. And they said, and these are geriatricians who I know mostly who wrote this, they said, you know what? If we're really going to redesign a healthcare system that stops valuing volume, procedures, that ICD-10 code book, if we're really going to change that, we're going to have to just think differently about what health is all about. And guess what? Here's a good way to think about it. Here's a group of scientists who've said, here's a different, better way to think about health. And it would lead to the so-called value-based way of thinking about health. And that would be much, much more informative for us. I've quoted a few things, and I encourage you to read this. It's a short one-page editorial. We'll avoid the cascading imaging test procedures treatment phenomenon. I can tell you I see a lot. So you come in, we think you have something, let's do a CT scan. Oh goodness, what is that little thing on the CT scan? We're not 100% sure. Let's stick a needle in it. Now we stuck a needle in it and, oh my God, you have a bleeding disorder. Now you're bleeding all the time. What are we gonna do? We have to stop that. And now we need a blood test to see why you're bleeding all the time. And on and on and on as we search for more and more small ways of thinking about health rather than a broad way of thinking about health. And if we're gonna redesign healthcare based on care site, the EMR and home-based care, we really should take this seriously. So that's the preliminary. Hopefully the silence in the room is you're thinking, oh, wow, that's interesting. How are we going to play this out? Linda's right. We're trying to write a book. The editor just sent me an email a few minutes ago. Where's the next chapter? So the book is called Re-envisioning Your Health, Living Well into Elderhood. This is not... this. I would never call Linda the sour kangaroo. Not that she knows. This is, there is no book, but it's at the publisher and we're trying to get this. What I want to just read is, we've tried to put in some patient stories. A lot of this has influenced just the way I practice medicine because I've tried to think harder and harder about how do I deliver better care for patients. And this is a real patient of mine who's given me permission. I just sort of show you the kind of anecdotes that I think we'll have in the book. So, before ending the visit, I asked Mr. Jones, he's this very well-dressed man who was a preacher who's recently retired, if there was anything else he wanted to discuss, the so-called doorknob phenomenon, we call it. So for the physicians in the room, you've done an hour with a patient, you're ready to leave, you walk out, you grab the doorknob. Is there anything else? And they go, oh yeah, by the way, the most important thing that you need to know, I just thought of it. Please don't leave. And just about then, an older, pleasant older African-American woman poked her head in the door. Where's Mr. Hervin Jones? I'm his wife, Sandra. Oh, nice to meet you, Miss Jones. We're just finishing up. I shook her hand. She nodded and gave him a quick look, indecipherable. As she turned, Hervin winked at me with a conspiratorial gleam in his eye. I guess there is one more thing, he said. He nodded towards his wife and he stage whispered to me, I have a bad case of womanitis. I was like, what? I was kind of confused. What do you mean? He says, I've got a problem with womanitis. A little louder this time, looking at Sandra. She won't leave me alone. Sandra smiled, rolled her eyes, and headed back to the waiting area. And it was my first hint that it was an important part of his health that I needed to better understand. There was a lot for me to learn. And in the book, you'll see, building on Linda's research, just how important. It turns out that Sandra's basically the key to his health. The fact that he's still going at all is because Sandra's taking complete care of him in every way you can imagine. And they have a very incredibly funny way of interacting with each other that we talk about. The other part of this story, and the reason I tell it, is if you look into the medical record, and I have his medical records from multiple hospitals, you would be hard-pressed to find Sandra listed anywhere meaningfully in the medical record, to be honest. It's under social health, it says he's married, says he doesn't drink too much and doesn't smoke, and says almost nothing about her. But until we met her, it was impossible to understand what was going on with his health. Okay, so that's the NSHAP piece. I hope I've given you a sort of a taste, and I'd love for you to join us in any way. Just about this time we were writing the book, I took this position in Southern California at City of Hope. I still remember Linda telling me, because she had worked in Southern California sometime in the past with the Rand Corporation, she said, in her usual way, I don't know if you're going to fit in out there. She gave me her reasons, and they were reasonable. But there was a position there as the head of the Department of Supportive Care Medicine. These are my colleagues there. This is my department, which has now grown to 170 people from the 75 when I joined there. And this is me and my family standing outside of the famous fountain there at City of Hope. So I had come away with this sort of discussion about how to treat health in a different way. And I had come up with this model, and I just want to give you a hint of, could we actually take this? Can you actually do this? So we have this healthcare system. What if I, not just with my individual patients, want to do something meaningful to take care of people who have a very specific disease, which is cancer, which is the epitome of biomedical model of health, and then put them into a care system. Also, I didn't bring, someone's going to have to signal me because I'll probably go over time and I want to stop. So here's a basic model of what I want to think about is, if you have all these measures, can you stratify people at the top? Can you put them into high risk, low risk, and medium risk categories? And probably there's high risk older adults, vulnerable, especially cancer patients, low risk. And there must be a way to sort people into better categories and then target interventions that will make a difference. And that your delivery system could be some combination of my two specialties, geriatrics and supportive medicine, where what we do is bring social work and bring psychology and bring a way of assessing that accounts for all these other ways of health being accounted for. So a whirlwind tour in supportive medicine, really what supportive care is the provision of compassionate expertise and an interdisciplinary team to the disease continuum, so you can manage symptoms, psychosocial needs, and help them find meaning in their life. It accompanies all these domains that I've talked about before. It's what the specialty is designed to do. Physical symptoms, the social domain, psychosocial health, spiritual interventions, and informational concerns, for example, interrelated domains of health that should make a difference if our model is right. Here's our department. This is just a little bit of showing you what we do and bragging a little. I love our departments. We take care of a lot of people with a whole host of different services that live under one umbrella, and includes our clinical divisions like palliative medicine, psychology, psychiatry, spiritual care, and also things that are less obvious, like patient and family education, cancer information resources, research programs, volunteer services. So here's one thing I want to show you about this. I do supportive medicine and it accompanies older people of all ages. But if you look at the most common reason people in a cancer center get seen, we screen them. We have 50,000 patients we've screened with this support screen to say, what is the top of the list, most important reason that you're here at the cancer center? And it's different if you're older. And it's exactly the same if you're older. Both things are true. So if you're younger at the top of your list, so to summarize this so I can move, if you look at the red items, they're the same for everybody. Part of being human and having cancer is you're tired, you can't sleep, you have a lot of side effects from all the stuff we're doing to you, and you're in pain. That's the same. But if you're a younger person, financial considerations are at the top of your list. Your life in the middle of everything has been disrupted and you're worried about finances and you are scared, anxious, fearful, afraid of how you're going to manage your life. If you're older, the things that are also at the top of your list are, I can't walk so well. I can't get around anymore. I'm having issues like I can't move my bowels. I'm in the bathroom. I can't go to the bathroom. My joints hurt and I can't get places. Those are completely different. And if you are treating each group the same, you're making a mistake. So you need to combine geriatrics and supportive medicine when you're taking care of older cancer patients. I like to take care of older people. I always have. I like them. They're full of interesting stories. They'll tell you things. I learn more from talking to my patients than about anything else because they know so many things. And we had a wonderful example this morning. But they also have a lot of other things that go along with being around a long time. You have more other diseases, including cancer. Your life is so psychosocially complicated. We asked our doctors to do evidence-based medicine on studies that didn't enrolled everybody younger than you because they don't have all these things that complicate clinical trials. So we actually don't know what to do. So we have to do evidence-based medicine with very little evidence. You get a guideline for every one of those diseases. You have a heart guideline to follow and a diabetes guideline to follow and a COPD guideline to follow, and they're incompatible most of the time. So you can't follow them. And then the doctor's there and we're all being asked to see more patients in less time. It's a complicated effort. So here's how we treat older patients. This is a little tongue in cheek, but it's turned into a recent program for me. We undertreat them. We say, you're this old, and so we treat you this way. And you might be a swimming champion at 80 who's should be treated like everybody else in terms of treatment choices for cancer. You might be a 65-year-old who's had a harder life and who needs different kinds of treatments. So we're undertreating, we're overtreating, and we're mistreating. Little personal sidelight, this is my mom. She's long jumping in the senior Olympics. She's a senior Olympian at the national level and can jump and run amazingly well. She's in the top 5 in high jump. When she got cancer, they asked what to do. She had ovarian cancer. She had a giant tumor. They took it out. She flew through surgery, had no problems, and she recovered, and she's back at the senior Olympics. When my father got cancer, he got lung cancer. He had every complication you could imagine. And he was a very inactive person and very socially isolated. He just liked to sit at home and watch CNN. He had a valiant fight, but he died in his late 60s from his lung cancer after a lot of complications. Two otherwise very similar people who probably would have had similar outcomes and had similarly serious diseases. I think the other things matter a lot. So we developed a geriatric assessment so that you could assess these other domains for people and tried to figure out that if we're going to start chemotherapy on you, are you likely to have toxicities from that treatment that will affect your outcomes? And after a lot of work, my predecessor and I helped her develop this CARG toxicity score, in which we can tell you before you start therapy whether it's about 25% likely that you're going to have a toxic response or 90%. It's far more accurate than anything the cancer doctors do right now. It's a little harder, as they remind me over and over again, but it's much more accurate to tell you what's going to happen if we start you on therapy. The fundamentals of that geriatric assessment are these social science assessments that I just described. As a consequence of that, ASCO issued its first geriatric oncology guideline, in which it said you should do geriatric assessments. I'm happy to be part of this team. You need to include essential domains of the kind I described. We can project your life expectancy better with this than anything else, as I've showed, and that you can enact interventions. The guidelines are being updated. Thankfully, they've come to ask my opinion, so I get to lead it, and we're going to redo them now. And here's the problem. So now we have these assessments. We know they work. We know they predict toxicities. Nobody will use them. The system is such that the oncologists don't think this way, and all they'll tell me, it takes so long, it's so hard, and we don't get paid to do this. And so this just shows very briefly, the blue bars are those who have actually read our guidelines, and the red bar are those who have not read the guidelines. This is 1,200 people across the country that we surveyed through ASCO. And so if you've read the guidelines, you're more likely to do it. You actually believe this is valuable enough to you as an oncologist that you'll do it, but only 25% of them will actually do it. The other thing is there's two reasons they won't do it. One, I told you, is that they just think it's too hard to do. The other thing they'll tell you is, I don't know what to do with it. So what? So I find out that they have some problem with their social life. What do you want me to do about it? It's not my job, roughly. So the system isn't set up to actually pay us to do the things that matter the most. And until we can fix that, we probably won't make any progress. Okay, this is my predecessor, Arti Huria, at City of Hope. She was one of the reasons I ended up going there to help build the cancer and aging research program. I wear a red hat. Arti tragically died 18 months after I got to City of Hope in a car accident. She was leading the field. She wore red all the time. So I go wear red hats everywhere. She wore red dresses. I can wear a maroon hat at University of Chicago and no one will ask except say it's a cool hat. You know, the dream, as we said, was to one day make sure these specialized approaches were done. This past year, we actually completed 2 randomized trials with over 500 people to say, if we have a geriatric assessment and we intervene with a multidisciplinary team, will that make a difference? Because that was the criticism. We knew the assessments worked, but we didn't know if we could intervene effectively. So these are my team, and these are the guidelines. Here's what I want to show you. So here's one study that was just published. I'm the senior author on these 2 studies, so I'm both conflicted and authoritative across them. They both found essentially the same thing. This is our study at City of Hope with 605 people, again in a randomized fashion called the GAIN study. What we showed was if you do geriatric assessments and have a trigger chart, like you can see over there on the right side, which intervenes with specific interventions along the lines I described earlier, you can reduce serious chemotherapy toxicities by 10%. Now, that may not sound impressive, but your survival is not changed at all, and you're 10% less likely to end up in a hospital or an ICU or dying after you get your chemotherapies. It also increases by 25% the likelihood that you will complete an advance directive, knowing that if things go badly, you do not want certain things to happen to you. And that rate in the baseline is about 10 to 20%. This is a second study that I was a senior author on, done at the University of Rochester through their NCORE network, found essentially the same thing with a different age population, 70-year-olds who had some kind of deficit on a geriatric assessment. They were 20%, they reduced their chemotherapy toxicity rate by 20%. They fell less often, and they discontinued medications at a higher rate, again, with no impact on their survival probabilities. So frailer adults, we can also do it, and they can be recruited into studies. So how does this work? So I'm getting close to the end, and that's good because this is one of the bottom lines. We did an accompanying study to the one I just showed called COACH, in which we tape recorded the interactions between the oncologists and the patients after they had a geriatric assessment or not. And what we found was the chances that you will talk about these other domains, falls, medications, your psychological health, goes up substantially if we force you to actually look at those dimensions in the geriatric assessment. So that conversation has to be had. And Rush Schmulvitz here from the University of Chicago told me, charmingly one day how much he hated my studies with him. And I said, really, why? He goes, they come in with so many questions after you do one of these interventions, I don't want to talk about. It forces them to have a conversation about things that matter. And I'm giving Russ a harder time than he deserves. He was a great partner. Also, when people walk out of that visit, they are substantially more likely, both the patients and their caregivers or partners, to be satisfied with the interaction that they just had with their doctor. They're much happier that someone took the time to go through those things with them that they see as relevant to their lives. Okay. We've developed a way to incorporate this into decisions. I'm fundamentally a decision-making expert in that avoiding overtreatment, undertreatment requires a better way to think about this. I'm not going to go through the details, but on one side, it's what's the benefits from getting treated for cancer and the likelihood of being cured? What's the risks of it from getting chemotherapy on that will make you sick and maybe kill you from giving you the treatments? And along the bottom, how do we know which patient should be in which group? An assessment like a geriatric assessment will tell you how frail you are or robust you are to make that decision in an informed way. And we're now putting in grants to study this. I'm going to wrap up just by flipping through this. The challenge now is all this stuff is done in academics, and in a little bit, it's 20% of cancer patients are seen in NCI designated cancer centers like the one I'm in. 80% are seen somewhere else out in the world with an oncologist who has no idea about this and who says, I can't do them, or too expensive. So the system has to be changed, and the structure of what we do has to be changed if we're going to make a serious difference. And we're starting to do this with a study out 60 miles from City of Hope in one of the more impoverished areas of Southern California, called Lancaster or Antelope Valley, with telehealth and a nurse practitioner and a good partner. And we have over 200 people in there, and we have some funding. I'm going to wrap up with this. We have set up 3 clinics at City of Hope now that are specific for older adults to get supportive care interventions. That's recognized on the national scene: an aging wellness clinic, the ABC program, and to bring it full circle, a place for my son to hang the sign in my SoCare clinic in Southern California, in which we are trying to build the infrastructure so that we can do this with people and not depend only on grant money, but on other ways of doing this. I'm going to stop here. I knew I would get to about here on our national infrastructure scene. Thank you for listening. It's a pleasure to be back at the University of Chicago. It's great to see Linda again, and I appreciate your time. Thank you.
Thank you so much, William. Lots to think about. We have about 10 minutes for questions. So you're going to check Laura, you're going to check online. So if anybody has a question for William, there's a lot going on here. Yes, please. Why don't you stand up?
Is it possible to slides?
Oh, yeah.
It's hard to see.
Yeah, no problem. I can just, yeah, I have so many slide decks. I can send you the long version, the short version, whatever you like. You're welcome to them.
How do we get them?
You want to email you?
I'll send them to the group, and then they
Send them to Luis. Okay,
I'll
so
send them.
Another option. This is all being taped. You can listen. You at your leisure. That'll be it.
Yeah, there's nothing proprietary in there, so you're welcome to take them and show people and anything. I'll check and make sure I'm not sending you anything you can't send.
We have one question online. How would telehealth approaches help advance the dissemination of this approach?
And so I'll just give me a chance to advertise how we've done it. So, you know, very little good came from COVID, but from a medical system perspective, the adoption of telehealth as a mode of interacting with patients has been pretty widely adopted now. Our approach, and it's just one of the approaches, is, you know, out at Antelope Valley, it's 60 miles around a mountain out in the middle of nowhere. And essentially there's no way to efficiently get anybody out there. So we do telehealth visits. They get an assessment from the electronic medical record online. So we send it to them, we email it to them if they prefer, and then we have someone in clinic who will deliver it. then that assessment is given to our nurse practitioner who lives in Duarte, where I practice. And they do a telehealth visit based on that geriatric assessment and supportive care assessment. And then locally, we look for local resources. So they can't come to us for physical therapy, but we look for someone there who they might be able to get it. So that's the approach we're taking. And we have a new grant from a foundation of $4 million to do this across 5 different cancer types now. Because I think the issue for oncology still is cancers are not one thing. They're like a whole bunch of different ones. Lung cancer is different than lymphoma is different. So you need to test them in each case. If an oncologist is going to approach it, they won't take a generic assessment. So we're building those.
Yes, sir.
Thank you for all you've done. My question is, in regards to critical diseases or ailments, have you done any research on metropolitan areas versus rural areas versus northern states and then southern states? Because what I find in the hospital systems is that when I go to the southern states, it's not as robust.
No, that's fair. I said this earlier, so I'll say it here. Man, I love his voice. And so there's undoubtedly differences, and we concentrated on the structural differences. It's been discussed a lot these days about structure, and I think you have to. When you see one practice, you've seen one practice in my experience in many cases. So how do you take these approaches that are abstract and apply them locally is, I think, what we have to do next to really make a difference. So when I went out to Antelope Valley, and I keep mentioning it, but it's out in the middle of nowhere in a very rural area, and I'm in close to where Pasadena is, which is, pretty different. This pilot study I showed you, we spent 3 years just figuring out how in the world we're going to deliver and communicate and get some resources that can't be the same. And so there's a group of people are trying to figure that part out so that we can be effectively delivering these some way. The electronic approach is a good one, but it is not. That's also infrastructure dependent. Let me put it that way. And who can and will be able to use it is, in some cases, worsening the divide rather than closing the divide because of the infrastructure needs. So the last thing I'll say is, money matters, and getting money where it needs to be, having a reimbursement system that cares is also state by state, and I'll leave it at that. Like, it depends on where you live on what's going to be covered as well. So I hope that gives a hint of it. We're working on it. And I'm glad we have a bigger group. And the second part of my talk was about national infrastructure. We need a national approach. If it's always just me and my place and you and your place, will never make progress either. It'll have to be bigger than that.
And there I am. Okay. A follow-up from the online telehealth question. Do you integrate your telehealth program with existing telehealth programs at the site or sites?
Yeah, mostly we try to work with the system we have, and at City of Hope, our community sites are in our electronic medical system, and our telehealth is integrated. That being said, man, that thing is frustrating. I use it every week myself with patients, and it fails almost as often as it succeeds just to connect. So that's one thing. The other thing is, people think everything can run through the electronic medical record, and when we try to get these assessments done in different places, some people want it in the electronic medical record. Some people want us to send an email. Some people want to talk to us in person and come into the clinic, and if you do one or the other, I think you miss the other third of people. So I think you need to be flexible, and the research side of what we do, we don't integrate, because the integrated system has central governance, and central governance takes 6 to 12 months to change one thing in the electronic medical record to get signed off from all the levels of the institution, and it's too slow. My grant will run out and they'll take money away.